Hi, I'm Dr. Milind Kharche. I'm interventional cardiologist, and today we are here to discuss about the latest update in hypertension. So, about a latest update, as per WHO, nearly 63% of total deaths in India are due to non-communicable disease, and of which 27% are attributed to cardiovascular deaths, which affects almost 45% of people in 40 to 69 years of age group. And raised blood pressure is among the most important risk factor for cardiovascular deaths. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. So here I'm going to discuss about points about updates and how we can improve awareness and care to improvise the patient care in hypertension. In India, the prevalence has gone up over 30 years to 38% in men and 32% in women, which is a high according to WHO. Despite nearly half of the people are actually unaware of the condition. They don't know they are having hypertension. And again, worse to that is almost 60% of the people are not treated. Means those who are aware, even they are not treated. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women in hypertension worldwide, according to WHO. So this is not a very good data as far as hypertension treatment is concerned. And as a medical fraternity, we need to improve a lot as far as awareness of hypertension is concerned, so that we can control blood pressure, hypertension better and bring down the morbidity due to hypertension, the cardiovascular risk due to hypertension. International Society of Hypertension has released an ISH 2020 Global Hypertension Practice Guideline, and the inclusion of optimal and essential treatment paradigms attempt to address the issue in poor resource setting. And it has defined optimal care and essential standards. So optimal care refers to evidence-based standard of care, whereas essential standard refers to minimum standard of care to allow specification of essential standard of care for low resource setting. Also, the ACC-AHA has released scientific statement in 2021 offering new guidance for management of stage 1 hypertension among patients with low ASCVD, that is atherosclerotic cardiovascular risk. Low ASCVD risk means 10-year CVD risk less than 10%. Those people having low ASCVD risk and stage 1 hypertension, the management start with non-pharmacologic therapy. Stage 1 hypertension here, according to ACC-AHA guidelines, means systolic blood pressure between 130 to 139 and diastolic blood pressure between 80 to 89 mm of Hg. So if patient with low ASCVD risk and stage 1 hypertension, then we need to start treatment with non-pharmacologic therapy, lifestyle management, exercise. And if in spite of optimal non-pharmacological therapy, lifestyle modification, the blood pressure remain uncontrolled for 3 to 6 months, then we should consider starting pharmacologic therapy. Lowering of systolic blood pressure between 130 to 110 range substantially reduce the CV adverse event in a step randomized trial, which affirms again the findings of SPRING trial, older Chinese population. So this is the second trial after the SPRING trial, which actually affirms the finding that stringent control of hypertension is beneficial. Among almost 8,500 patients between the age of 60 to 80 in China, the intensive target trimmed the composite CV risk almost by 26%. And I think finding from this study may unite all the professional guidelines, even among US, the all professional societies. Threshold for blood pressure control varies from 130 to 150. Like ACC say it's 130, other guidelines say it's 140, and some are up to 150. But yes, now the evidence is emerging that more stringent the blood pressure control, more reduction in cardiovascular deaths are observed. So it is better to have a proper stringent blood pressure control, at least in those who have high CV risk. Now, with regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, 2018 European guideline on management of arterial hypertension recommended that the diagnosis of hypertension should not only be dependent on office BP measurement, but also on out of office measurement, such as ABPM, that is ambulatory blood pressure monitoring, or HBPM, that is home blood pressure monitoring. So 24-hour and nighttime BP measurements were associated with greater risk of mortality and composite CV outcome. So that means we should target a home blood pressure or ambulatory blood pressure. In India, using ambulatory blood pressure monitoring for each and every patient is not practical and feasible. So obviously, a home blood pressure monitoring is a choice for us, and we do prefer it. And according to guideline also, we should target the home blood pressure monitoring for blood pressure control. And thus, this may be considered as a most relevant measurement for estimating CV risk. So for every 20 by 10 mm of Hg increment in BP measured at night or at home, the risk of mortality increased almost by 23% and the risk of cardiovascular event by 36%. So this nighttime BP measurement or out of office BP measurement correlates well with the CV risk, and controlling it obviously going to correlate well with the CV risk reduction. So whenever we treat hypertensive patient, we should consider this out of office BP measurement so that we can have better result in CV risk reduction. Again, the 2018 European guideline equally recommend 5 classes of antihypertensive drug considering high non-adherence treatment. The importance of combination treatment is particularly highlighted to improve adherence to the therapy and BP control. And that's why this guideline in context of lower BP target advise to start antihypertensive therapy with initial dual fixed drug combination of ACE inhibitor or ARB plus CCB or diuretic. So according to patient profile, we need to choose a fixed drug combination to start with, not in a stage 1 hypertension, but those who are having stage 2 hypertension. I think most of the patients require 2 drugs to have optimal blood pressure control and to achieve the blood pressure control targets. Since early July 2018, there was an issue with valsartan worldwide, and I think as a practitioner, which we treat a hypertension patient, we should know this issue about valsartan. And the reason was detection of a known carcinogen, namely N-nitrosodimethylamine, that is NDMA, which was found in many sartans like candesartan, irbesartan, losartan, olmesartan, and valsartan. And it was specifically related to manufacturing by a single Chinese firm, Zhejiang Huai manufactured pharmaceuticals, and this was associated with increased risk of hepatic cancer. And this valsartan has been recalled by FDA worldwide, and in most of the countries now, valsartan from this firm is not available. Luckily, valsartan manufactured by 2 Indian companies is actually given clearance by US FDA, and it's now available in Indian market. We can use safely that valsartan for the treatment of hypertension. Another important update about a HYGEA study, which represent the largest study that tested a nighttime antihypertensive treatment. In this trial, chronotherapy was associated with significant reduction in endpoints, including death. The HYGEA chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening hypertension therapy, means whether you should give drugs, hypertension controlling drugs at bedtime or in the morning. So they compare both, and giving hypertension controlling drug at night time actually exert a favorable CV risk reduction. The largest study included a total of almost 19,084 hypertensive patients. During an average follow-up of 6.3 years, 1,752 participants experienced a primary CV outcome. An ambulatory blood pressure measurement was performed for 48 hours and to collect the data on how BP differed during the sleep. And the relative risk reduction for CV event was significantly improved for nighttime treatment. So there was significant CV risk reduction in a patient who received medication at night time than those who take in the morning hours. So it is important to control a nighttime blood pressure to avoid increased CV risk reduction. So these were few important updates when we consider treating hypertensive patient. I hope it's useful for you in your daily treatment or managing a hypertensive patients. Thank you.